All righty, we're going to start with a quick little exercise. Everybody, let's see, hold out your hands. Let's see, get everybody to hold out your hands just like this in front of you. Now, your goal is the following. Your goal is to follow me and do exactly as I do. Okay, this is post-lunch, so let's see if everyone's paying attention in a good state of mind. All right, no, that was just me clapping, but that's okay, good. Good job, I appreciate that. All right, hold your hands out in front of you just like this, and I want you to take your hands and turn them inwards so your palms are facing outwards, just like this. Take your right hand over your left hand. Close it just like this. You probably did this when you were a little kid, right? Everyone could probably do this. Good, excellent. Go back out just like this. Now put it up a little bit higher. Put up a little bit higher, Jen, a little bit higher. Perfect. Just make sure your thumbs are down. Right hand over your left. On the count of 3, do exactly as I do. Ready? 1, 2, and 3. There you go. A little round of applause for yourself. Now, what is the reason that I made you guys go through that exercise, besides the fact that it's really fun to frustrate a room full of medical professionals? What is the reason that I actually made you go through and do that? And the reason is because I wanted you to experience what it feels like to fail at something that has nothing to do with how hard you're trying. It has nothing to do with that. And when it comes to opioid addiction, a lot of us think about it in the same way. And it's important to think about it, that opioid addiction is not a moral failing. It's not because someone is not trying hard enough. It's chemical imbalances in the brain that are creating situations where they cannot stop taking the drug. And as a result, they need medication in order to treat this affliction. My name is Salil Bhandari. I'm an emergency medicine physician down in Houston, along with Dr. Hillary Fairbrother. And I've been down there for about a year or so now. And my point today, that what I want to talk to you guys about, is how we can actually bridge that gap between opioid addiction and opioid recovery in the ED itself by starting patients on their addiction treatment in the emergency room itself with buprenorphine. So, what exactly is buprenorphine? I'm sure a lot of you guys have heard of it. Maybe some of you have it in your ED, some of you guys don't have it in your ED, but it's essentially a sublingual film or a sublingual tablet that is a mu receptor agonist that you take to treat acute withdrawal, as well as it's your daily dose for treating chronic addiction as well at the same time. Buprenorphine, when you take it, it allows people to function normally. They can go to work, they can take care of their family, they can take care of their kids, do whatever they need to do, as opposed to other types of treatments which oftentimes don't allow that. And so patients can functionally live normal lives when they take this on a daily basis. Now, you might know buprenorphine by its more common name, by its trade name, or sorry, by its by Suboxone, that you oftentimes see it on the box as. And Suboxone, however, is composed of both buprenorphine as well as naloxone. So there are 2 components in it, and I'll take each one and kind of explain what the purpose of each of those is. So buprenorphine, first of all. So buprenorphine, in order to understand how it works, you need to understand 2 concepts, and that is affinity, and you need to understand agonism. So buprenorphine has a very high affinity for the mu opioid receptor. It has a higher affinity than most other opioids. That means if you're on buprenorphine and you take heroin, for example, the buprenorphine will make sure that that heroin does not bind because it has a higher affinity for that receptor than the heroin does. And that's why it's such a good drug, because it can essentially displace all other opioids that you have on board. So it has extremely high affinity for that mu opioid receptor. And the second thing is, when it does bind, it only activates that receptor partially. So why is this important? Why does this make sense? Because this has 2 really important factors when you actually look at why this actually works. And because it only partially activates that receptor, you get a ceiling effect, which is a beautiful component of this drug. Is you have the ceiling effect that even if you overdose on buprenorphine, you're likely not going to get that respiratory depression like we see with other opiates. You're likely not going to get that euphoria that you see with other opiates, because it only activates that receptor just a little bit. So it has partial agonism at that receptor. And also, because of that partial agonism, it prevents a lot of those physical withdrawal symptoms and cravings from happening, which is the reason why people end up using opioids over and over again. So it's such a wonderful drug because of these reasons. It has high affinity and it has partial agonism. So now naloxone, there's a lot of discrepancy, a lot of misthoughts out there on why naloxone is oftentimes included with buprenorphine. Naloxone is there for a very specific reason, and that reason is, And that reason is essentially to prevent abuse from happening. That's the reason why naloxone is in there, because when naloxone, when it's in there and it's taken normally, if you take the Suboxone normally, as directed sublingually, that naloxone is essentially inactive, it's inert, it doesn't do anything. But if you try to tamper with it, and if you dissolve it and then try to inject it, then the naloxone is going to become active. And that's why it's in there, because when it's active, then patients will have some sort of an unpleasant withdrawal, and hopefully they're not going to go through that experience again. So the naloxone is specifically in there to prevent abuse from happening. So does buprenorphine actually work in the real world? Does it actually have data? And I think the best evidence for this is probably France, that had their opioid epidemic in 1996. And when they actually introduced buprenorphine into their communities, they saw massive drops in heroin overdose deaths in their communities. Over 80% decrease in opioid deaths in their communities over a 2-year period. They essentially knocked out their entire opioid epidemic as soon as they started introducing buprenorphine into their communities. Incredible. Now, the thing is, though, we need to start bringing this into the emergency department. I know a lot of you guys are thinking, what does it have to do with us? We don't really treat addiction and all that, but the key is we have to start treating addiction, and that's the new mindset that we have to start changing ourselves to, is that we have to start treating addiction in the ED, because this is where the patients come to. This may be their only contact with the healthcare environment, may be their ED visit at that time. And if we're not actually beginning their addiction treatment in the ED, we're missing out on a huge number of people that could benefit from this drug. So how do you actually do it in the ED? Some of you guys may have Suboxone programs in your ER, some of you may not. And if you don't, I want to show you guys how to actually do this. So in order to do it, you need to have your ER also connect with other partner community clinics that are outside, so patients can get their first doses of Suboxone in the ED, but you also have a system in place so that they can make sure they continue to get their Suboxone after they leave your ER. So you have to have an ED community program, and you have to start these programs in your ER in order to do this. So the first step is initiating buprenorphine. So how do you actually initiate it in your ER? The key is you want to make sure that the patients are in mild to moderate opiate withdrawal when you actually give it to them. And what's the reason for this? What's the reason that you want them to be in withdrawal when you give it? Because if they are not, they have a full agonist on board, right? You have a full agonist on board, and if you have a partial agonist that you give them, they go from a full agonist to a partial agonist, and they're going to drop and essentially go through that withdrawal symptom. So essentially, if you give them buprenorphine and they're not in withdrawal, you can induce a withdrawal in those patients, and it can be very unpleasant for them, and then they'll associate buprenorphine with the bad drug that gave them that withdrawal. So you want to make sure that they are in mild to moderate opiate withdrawal before you actually give them the drug. So how do you do it? Well, we start off with kind of a lower end dose of around 4 milligrams or up to 8 milligrams. No X waiver is needed. If you guys don't know what an X waiver is, an X waiver is essentially an addition to your DEA license that you can get. It takes about 8 hours of training to do, that allows you to prescribe buprenorphine. You do not need an X waiver if you just want to administer buprenorphine in your ER. You do not need an X waiver for that. So you give them 4 to 8 milligrams of buprenorphine. You're going to observe them in your ED for some period of time, maybe about 30 minutes, 45 minutes, up to an hour. And then if they need more, if they're still in withdrawal, you give them another dose of buprenorphine until the withdrawal symptoms are abated, and then you can continue on from there and make sure they follow up in the community clinics. So after they leave your ER, you have to make sure that they have follow-up in some sort of a community clinic that can continue to prescribe buprenorphine to them on a daily basis. However, that may take a few days, so what do you need to do? You need to also give them some sort of a bridge up until that point. So how do you actually do that? Well, if you have an X waiver, you can make sure to actually prescribe them, but I know many of you probably don't have an X waiver, so how do you actually accomplish this? Well, you can also do one other option. If you don't have an X waiver, you can have them come back to your ER 2 more times to receive another dose for buprenorphine before they follow up in that clinic. Okay, so that's still, even if you don't have an X waiver, you can still have them come back the next day for another dose of buprenorphine, and the day after that. For 72 hours, essentially, they can get treatment, and you don't need an X waiver in order to do that. Make sense? So does it actually work in the ED when you initiate it? We know it works in general, but if you initiate it in the ED, Gail D'Onofrio and her colleagues up at Yale were probably one of the pioneers in this, in initiating in the ED. And they found essentially when they initiated it in the ED, those patients were twice as likely to be retained in treatment at 30 days compared to those patients that did not. And this has been replicated up to about 2 months. And even in our program down at McGovern Med down in Houston, we have retention rates at 6 months of around 63%, which is fantastic and wonderful for a drug like like this. So if you want to know how to actually start it in your ED and how you can actually create a program in your ED to do this, then this is a great place to go to. ED Bridge is a great website from an emergency physician down in Oakland, Andrew Herring, and he talks about how you can actually start this program in your ER itself. And also my colleague, Dr. Ruben Strayer, has a website called EM Updates where he goes through a lot of issues on how you can actually start this in your ED. So in general, I plea you guys to, if you don't have this program, start these programs in your ER, talk to your administrators, and really get them going. And I promise we can really make a big dent in the global epidemic that we have in front of us in terms of opioids. Thank you guys very much. Ooh.